What would you recommend for MIPS measures for the easiest, best, most efficient measures for an ophthalmologist?
Great question, Carrin, and a difficult one. Ophthalmology, I think, is one of the more challenging specialties to deal with. There's not yet an ophthalmology MIPS value pathway, so you can't go in that direction. Now, there is an ophthalmology specialty measure set. A typical advantage of a specialty measure set is that if you do them all, or all that apply to you, you get full credit, even if you don't have 6 measures. But there are 15 measures in the ophthalmology measure set, including a couple that apply broadly, but could be an awkward fit. First, there's 5 general measures that theoretically apply to any provider or nearly any provider, but could be an awkward fit in ophthalmology. It's measures 130, documentation of current medications in the medical record; 138, tobacco use screening and intervention; 238, use of high risk medications in older adults; 374, closing the referral loop, that is receipt of a specialist report; and measure 487, screening for social drivers of health. I think these all generally fit in most specialties and they can fit in ophthalmology. But as a referring primary care physician, I don't think I'd be looking at these specifically if I were judging the quality of the doctor to which I was referring my patients. There's a single measure about macular degeneration, that is number 14, dilated macular exam. There are 2 diabetic eye measures, one diabetic retinopathy, communication with a diabetic provider, and 117 diabetic eye exam. There's one open angle glaucoma measure, number 141 intraocular pressure. There's 4 cataract measures. That is 191 visual acuity 90 days post-op, 303 functional improvement 90 days post-op. Now, measure 304 patient satisfaction 90 days post-op. And number 389, the difference between planned and final refraction. There are 2 retinal detachment measures. Number 384, no return to the OR within 90 days. 385, visual acuity improved in 90 days. There's also a couple of EMA clusters. That's EMA, EMA, which is eligible measure applicability. Medicare looks at these measures, and if you submit any one of them, they expect you to be able to submit all the others in the cluster. So if you submit one cataract measure, you should submit all 4. If you submit any one of the 3 internal eye care measures, they expect you to submit all 3. Those 3 internal eye care measures are the 2 retinal detachment and repair measures and the open angle glaucoma measure. There are 2 Part B claims measures, number 141, the open angle glaucoma measure, and number 226, the tobacco use measure. So if you're a small practice, that is 15 or fewer providers, you're eligible to use Part B claims, and you could do those 2 measures for a complete submission. Now, the American Academy of Ophthalmology also operates a QCDR called the IRIS registry, and they have 26 measures. Now, Medicare doesn't require to use the QCDR. Um, if you can find a 6-measure set or a smaller set that you can justify through one of these rules, that is fine. That is good. Now, if you're a solo practitioner or in a small practice, if you're 15, you can use the Part B claims method or perhaps the cataract set or the internal eye measure set. But if you're in a large group, and I know in large groups, there's often compartmentalization of the various eye problems. One person doing cataracts, another doing retinas, another caring for the diabetic eyes. So together, you can choose the 6 best measures and put in a group submission. I think it's particularly hard um, as a practitioner in a group practice. Um, to individually submit 6 measures, you'll run into some rules that'll limit your choices. We're happy to help. One thing you'll want to do as you're going through this is have an expert in your pocket to help do the eligibility screening, to help you justify to Medicare when you don't have enough patients to report any of these measures. Uh, if you get a first pass denial of your submission, you may need to put in a targeted review request after the scores are released. And again, proving that you have not enough patients for some of the measures, or that they don't apply to your practice, are going to be critical to having a winning submission.